No, it's going to give me a hard time real quick. But share screen. Share screen. Okie dokie. It's going to be tiny here in the corner. All right, so we're moving through this exam. There was a lot of questions that really should have been easy to kind of what's the word? I guess logic through. So, and then some of them were kind of more BLS themed, and I think that might have thrown some people. So, first question: you were on scene with a patient, 55-year-old male with a history of stroke, complaining of chest pain. You decide he should receive aspirin orally. Which of the following is important to verify before administration of an oral medication? All right, so we don't adequate water, wash down pill. We don't use that. We don't use water in the pre-hospital setting to swallow pills. Ability of the patient to swallow an oral medication. I like that one so far. Ability of the patient to recite the dose of the aspirin. We are taking exam questions for this patient. Adequate aspirin for the remainder of your shift. That's when you go out of service and go get more. So, ability of the patient to swallow oral medication. Next up, left main coronary artery subdivides into. So, I don't know if you remember the heart, right? So, it goes the right coronary artery, and then you have the left coronary artery, which divides into the left anterior descending, and the circumflex, which goes around the back. So we look for that left anterior descending. There is so also if you look at the questions here, we didn't even talk about a left posterior ascending. Okay. First of all, there's no anterior ascending. There's no posterior ascending. It's descending. Okay, so those two are automatically get themselves crossed off. Right coronary and left posterior descending. Okay, the right coronary artery comes right from the coronary, like the original coronary. It does its own thing. It doesn't associate itself with the left main coronary artery, which we were looking at. Left anterior descending and circumflex. Oh, there's your answer. Let's see if I can scroll this down without making it angry. Nope. All right. Electrical wave moving in the direction of a positive electrode, right? So we talked about it when we talked about Einthoven's triangle, right? So you have the negative and the positive, and the electrical wave that's moving across the heart is positive. So a positive moving towards a positive is positive, just like a negative moving towards a negative is positive. It's sort of like that, that 7th or 8th grade math. So if you have a positive, an electrical wave, which is going to be positive, moving in the direction of a positive electrode, you will have a positive deflection. Artifact has nothing to do with electrical wave. Manifest with a narrow QRS complex. I mean, maybe, maybe not. We can't guarantee this for sure. This here is your distractor. And cause a negative deflection on the EKG. No, because if it's a negative wave moving to a positive electrode, then yes, it would cause a negative deflection. If it was a positive wave moving away from a positive electrode, you'd also have a negative deflection. All right, so moving on to the next set of questions. All right, hypomagnesia. This one was more of a, do we remember what we read and what we did in our assignments? What does hypomagnesia do in the body? The whole question is actually what hypomagnesia would most likely result in. So it's definitely going to be a decrease, obviously. The answers here kind of tell you that. And this was just a memorization, and it was decreased cardiac conduction. Moving on. Which of the following, hold on one sec. Which of the following most accurately describes an acute myocardial infarction? All right, hold on. Let me move this down a little bit. Oh, no, everything is there. I just didn't do a good job of... All right, so our options here: injury to a portion of the heart muscle secondary to atherosclerotic disease, damage to the left ventricle following occlusion of the left coronary artery, death of the myocardium secondary to a spasm of a major coronary artery, necrosis of a portion of the myocardium due to a prolonged lack of oxygen. All right, so it's not the left ventricle, right? Because you can also do, it's not specifically the left ventricle, because, or the left coronary artery, because any of the arteries involved could be involved. Death of the myocardium secondary to a spasm, it's a possibility that it's going to be spasm, but most of the time it's due to a clotting issue. And then on top of that, does it always have to be a clotting issue, or is it always atherosclerotic disease? This is your distractor, okay? The real most accurate definition of a myocardial infarction is necrosis of a portion of the myocardium due to a prolonged lack of oxygen, right? This right here. That's your clue. All right, moving down. Okay. Percutaneous coronary interventions, right? PCI, we talk about this is when you bring that patient up to the cath lab. What does it usually involve? Passing a 2 millimeter catheter through the femoral artery to administer a fibrinolytic agent. You had me there until the fibrinolytic agent, because they're not always doing that. Most of the time they're using a stent, correct? So no. Using a large vein from one of the lower extremities to reroute blood flow past an occluded artery. This is a cabbage. It's coronary artery bypass graft. Passing a guide wire through one of the external jugular veins to directly visualize an occluded coronary artery. They usually don't use an external jugular vein, right? This is usually through the femoral artery that we're going up. Occasionally they'll also use the radial if they're feeling feisty that day. So it's not that one. So recanalizing a blocked coronary artery by passing a balloon or stent, this is your magic right here, a stent, through a catheter via a peripheral artery. Okay? There's your answer. Most patients with an ST elevation myocardial infarction present without chest pain? No. Heal without treatment? Also a no. Experience cardiac arrest? Maybe. Possibility. Will develop Q waves. This is your answer. Not everybody dies, thankfully. Usually we do manage to swoop in and save them. All right, a prolonged PR interval. So this means knowing what your PR interval is to begin with, right? So anything longer than 5 little boxes, right? Little boxes, which is 0.2 seconds, right? So is greater than 120 milliseconds, maybe. Indicates the AV node was bypassed. No, that would give you a short PR interval, right? Because that PR interval is from when the atria is depolarized to when it goes through the AV node to the QRS. It's a really sexy QRS, right? So a prolonged would not bypass the AV node. It's going to stay too long at the AV node. Prolonged interval is a sign of rapid atrial depolarization. Again, you'd most likely have a shorter AV node if it's going to get stuck at the AV node. You're going to be looking at the PR interval. Atrial depolarization is the atria, so you'd have a little teeny tiny, cute little P wave. So no. It indicates an abnormal delay at the AV node. Right there. That is your answer. Moving on. All right. Okay, stable angina typically subsides within 10 to 15 minutes. Maybe. It's a possibility. Characterized by sharp chest pain rather than pressure. No, usually it's pressure, kind of regardless. Occurs after a predictable amount of exertion. Usually requires both rest and nitroglycerin to subside. This right here, the both, that's usually a good sign in a multiple choice question that that's not what you're looking for. So now you've got it down to these two, right? A and C. Typically subsides within 10 to 15 minutes or occurs after a predictable amount of exertion. It's predictable, okay? That should be your clue. Predictable, right? So 10 to 15 minutes is a nice span, but it could be longer, it could be shorter. Really, the best answer is C, occurs after a predictable amount of exertion. Most common symptom directly related to blood pressure elevation is headache, epistaxis, dizziness, or blurred vision. These are all very, very common. The difference between an elevated blood pressure and a hypertensive crisis is the development of like end stage issues, right? So end stage issues would be epistaxis, blurred vision, right? Those end organs are being damaged in one way, shape, or form. And dizziness, right? Dizziness is a little more significant than a headache. So that's your answer, is headache. Moving along. Myocardial ischemia. Come on, my little pen back. Myocardial ischemia occurs when the heart muscle is deprived of oxygen because of a blocked coronary artery. Okay, possibility. Suffers oxygen deprivation secondary to coronary vasodilation. Okay, if the vasodilation means it's getting bigger, that won't deprive it of oxygen. It'll probably bring it too much oxygen, so that's not the answer. Experiences a decreased oxygen demand and an increased supply. Okay, so my O2 demand is up, but my supply of O2 demand is up. Supply O2 is down. Okay, I like that one a lot. That one sounds good. Undergoes necrosis because of prolonged oxygen deprivation. This is when you start moving. Necrosis is when you start moving into injury, right? We just want to know about ischemia, so that's not the right answer. So now you're going between A and C. Can you have myocardial ischemic events due to anemia, or due to hypovolemia, or any other loss of red blood cells? Yes, which is really, in the bigger scheme of things, a supply and demand situation problem. So your answer is C. Damage results to the cardiac electrical conduction system caused by an acute myocardial infarction most commonly results in, right? So that's your SA node, right? Your intranodal pathways, your AV node, and your bundle of His and Purkinje fibers, right? So if there is some sort of damage to any of these, any of this electrical pathway, right, there's going to be some sort of issue, right? Traditionally, you don't really see severe tachycardia, right? Tachycardia really is more often seen when you have a really good intact electrical conduction system. It may or may not be ventricular or atrial. We can't say because they don't specify. They just say the cardiac electrical conduction system. Could be anywhere along this pathway. So both A and C are out, which means that B, bradycardia or heart block is your most accurate answer. All right, you respond to a 55-year-old man complaining of severe pain that began suddenly between his shoulder blades. Describes pain as ripping in nature and that it has been unrelenting since its onset. Medical history includes hypertension, admits to being non-compliant with his antihypertensive medication. Tisk, sir. Which of the following assessment findings would most likely reinforce your suspicion regarding the cause of his pain? So the first thing you need to do is kind of have a suspicion as to what the cause of his pain is. Your major clue here is sudden onset of severe pain, and ripping in nature. That really should kind of give you the idea that he's in the middle of a AAA. So what most kind of commonly fits that, right? ST segment depression on the E12 lead, no, not really. Disappearance of radial pulses during inspiration, no, I would say that doesn't fit. That's more of a chest wall issue, not necessarily, a AAA problem. Bruits to both carotid arteries during auscultation, no, that would be more associated with stroke. Difference in blood pressure between the two arms. This is your answer. Right, so we remember that as the aorta comes up off of the heart, the acute heart, it divides into the subclavian arteries. And if you have a tear in that's a really horrible picture, but if you have a tear in the edema and that blood is going in here, it's going to have a significant level of difference between the right and the left arm when it comes to blood pressure. That's your hallmark sign of a AAA. All right, more questions about aspirin, which is a BLS skill, which really should have been, easy for you guys. I thought that was kind of a giveaway. When administering aspirin to a patient in acute coronary syndrome, you should give up to 325 enteric-coated aspirin for the patient to swallow. We don't swallow aspirin, we chew, right? We're savages here in the streets. And we also don't use enteric-coated because this delays absorption. So, not that one. Have him or her chew. All right, good. Swallow 160 with 325. Okay, like this one so far. Administer half the usual dose if they have a history of stroke. That makes 0 sense. First, check to make sure the patient is not severely hypertensive. That has nothing to do with aspirin. Best answer, B, have him chew or swallow 160 to 325. The farther removed the conduction tissue is from the SA node, right? So we talked about this, right? SA node. Here's my really good drawing, internodal pathways. AV node. Bundle of His, Purkinje fibers, right? So we talked about this. If the SA node has an intrinsic rate of 60 to 100, and the Purkinje fibers have a conduction rate of 20 to 40, right? Because they're the furthest away from the SA node. Here's 40 to 60. Is it going to have a faster intrinsic rate of firing? No. Will the QRS complex be more narrow? No, because the SA node has the narrowest. It's like this Snow White. It's like the evil queen in Snow White. It's the narrowest of them all. The slower the intrinsic rate of firing, I like that one, and the longer the PR interval. You might not even have a PR interval if it's being, conducted from down here, right? If you have an idiosyncratic an idioventricular rhythm at 20, there is no PR interval. That's not it. So, here's your answer. All right, rolling along. Oh. Okay, so which of the following chemicals or drugs causes an increase in heart rate? So this is a little bit of knowing medications and also a little bit of knowing your protocols, right? So atenolol, right, your LOL, that's a beta blocker. So that right there does not increase heart rate. That slows that down. Even if you're like sitting here going cholinesterase, I don't remember this one. Oh no, brain block. You can kind of just like sit that to the side. Verapamil, right? This is a calcium channel blocker. It's blocking things. It's not speeding it up. Atropine and epinephrine. We give atropine in Brady dysrhythmias. We give epinephrine during cardiac arrest, which, if, we talk about cardiac arrest and how epinephrine can bring hamburger meat back to life, that's going to increase your heart rate. So even if you're sitting here going, I don't even remember what cholinesterase does, oh no, so sad, atropine and epinephrine. P wave represents This should have been a giveaway, dead giveaway. SA nodal discharge, contraction of the atrial depolarization, and delay at the AV node. We don't have the delay. That's your PR interval. That's a terrible. There we go. PR interval. Atrial depolarization, contraction of the atria. The EKG doesn't give you mechanical, right? That's your pulse. So that's not it. SA nodal discharge. Okay, that's the beginning of the P wave. That right there. SA nodal discharge is the indicator. Your answer is atrial depolarization. Numerous connections of blood flow among the arterioles of various coronary arteries, which allow for the development of alternate routes if a larger coronary artery begins to narrow, are called what? Okay, so I can maybe see how one of these answers could have thrown you off. So cardiac myocytes, this is the muscle cells themselves. So that's not it. Coronary sinus, this is where blood comes back before it goes into the right side of the heart, the deoxygenated blood. Collateral circulation or coronary microcirculation. See, I can see how coronary microcirculation might have thrown people for a loop, but the best answer here is collateral circulation. Moving along. Come on. The Levine sign. All right, so the Levine sign. Come on, give my pen back. Right, the Levine sign. We talked about that. We talked about how that's the that inadvertent clutching of the chest. Right. There's your answer, right there. It's not a state of denial. Pushing on the sternum with the fingertips. I mean, no. It's more of that clenched fist. Rubbing the arm to which the pain is radiating. No, that's not it either. All right, best view of the anterolateral wall of the left ventricle, right? So we set up our V1, V2, V3, V4, V5, V6, like we would see, right? In the 12 lead. So it's S, A, L, O. So we want anterior and lateral. Okay, so V2 is septum, V3 is anterior, no. V4 and V5, anterior lateral, cool. V4 to V6, that's more anterior and lateral. V5 and V6 is just lateral. All right, so now you have two options, which is going to give you the best view, right? It's going to give you the most leads. Going to be here is your V4 to V6, right? Because it gives you a +1 over this one here. Okay. Next set of questions. And a patient with left heart failure and pulmonary edema. What is going on? The right atrium and ventricle pump against lower pressures, resulting in systemic pooling of venous blood. No. Pooling is caused by higher pressures, not lower pressure, so that's not right. Diffusely collapsed alveoli cause blood from the right side of the heart to bypass the alveoli and return to the left side of the heart. This is a different disease process altogether. This is usually what you're seeing in a PE. It's shunting. Okay, so no, that's not it. Increased pressure in the left atrium and pulmonary veins forces serum out of the pulmonary capillaries and into the alveoli. All right, that sounds right. We're going against increased pressure, right? It's the left heart failure, so the left atrium and pulmonary veins, because right, it comes back from whence it came. So if the left side is damaged, it's going to go back to the lungs. That's where the heart's coming from, so it goes through the pulmonary veins. An acute MI or chronic hypertension causes the left ventricle to pump against a decreased afterload, resulting in hypoperfusion. Again, we're looking for something that's increased afterload, right? The pressure in the body is too much for the heart to handle. So decreased afterload would make it easier for the heart to pump, not more challenging. So your best answer here is C. On an EKG graph paper, 6 seconds is how many large boxes? Okay, so there's a little math question for you, right? So if one large box is 0.2 seconds, no, okay? Or alternatively, actually, let's do it this way. Eraser. So you have one large box. That would be large box, 0.2. You want to know how many boxes is 6 seconds, right? So 6 equals 0.2x. You're going to divide 6 by 0.2. Means you move this decimal point over 1. You move the imaginary decimal point over 1. 2 goes into 60. 30 times, there's your answer. If the heart's secondary pacemaker becomes ischemic and fails to initiate an electrical impulse, right? So we got your SA node. I'm really getting good at this picture. Your internodal pathways, your AV node, and then your Purkinje fibers and your bundle of His. So if your AV node craps out and fails to initiate an electrical impulse, P wave and PR interval will have an abnormal appearance. I mean, maybe that's if you have a P wave, but hold on to that one for now. You will see a brief period of bradycardia followed by asystole. No, because hopefully the next path or the next pacemaker picks up the slack. AV junction will begin pacing at 40 to 60 times a minute. They just said that the AV junction became ischemic and failed. So no, you should expect to see a heart rate slower than 40 beats a minute, right? Your intrinsic rate down here, which we just talked about above, is 20 to 40. So here's your best answer. On the roll. Okay. A prolonged QT. So again, let's remember what the QT interval is. You have your P, you have your PR interval, and yes, this is really, and then you have your QT. So this part becomes extended, and then you have a ways to go before your T wave. Let me fix this terrible drawing. There we go. If your prolonged QT interval indicates that the heart's depolarizing too quickly, no, because your QT interval is telling you right before repolarization, not depolarization, so no. Shortened refractory period may be caused by factors such as hypocalcemia and pericarditis. No, because now if you remember, your refractory period goes from here to here. So if you have a prolonged QT interval, your refractory period is extended. So no. Is experiencing an extended refractory period, okay, making the ventricles more vulnerable to dysrhythmias. I like that one so far. Has a shorter than normal refractory period, increasing likelihood of severe bradycardia. No. C. A runaway path pacemaker is characterized by narrowing the QRS complexes. No. Absence of pacemaker spikes. No. Probably have too many pacemaker spikes. Tachycardic pacemaker rhythm, yes. Or profound slowing of the heart rate. It's running away, which means it's going to be faster. Tachycardic pacemaker rhythm. Apparently had a small stroke right here. All right, you are called to a local gym for a patient with nausea. Patient's a 29-year-old man, conscious and alert, complaining of shortness in breath and being nauseated for 4 hours. No vomit, believes he has a stomach bug. His blood pressure is 124/66. Pulse is 46 minutes and strong. Respiration is 20 breaths and regular. Room air saturation 99%. Cardiac monitor shows sinus bradycardia. What should you do? Apply high-flow oxygen non-rebreathing mask, start an IV lines, administer atropine, transport. You had me until atropine, right? You have this young, healthy 29-year-old who's at the gym, of all places. This is the gym. With a heart rate of 46 beats a minute, I'm not concerned about 46 beats a minute for somebody who goes to the gym on a regular basis, frankly. No. Advising me can probably drive himself to the emergency department or schedule an appointment with his physician. I mean, as tempting as that one is, no. It's just poor form. Give 100% oxygen, 2 large bore IVs, and administer 20 milliliters of normal saline. That's aggressive for no particularly good reason. I mean, you don't need 2 large bore IVs on a guy with a blood pressure of 124 over 66. That's, I mean, you see this when you have a medic student on the truck, right? You start 2 large bore IVs. But no, administer oxygen, nasal cannula, start IV normal saline, and consider an antiemetic. Yes, and transport. Right? He's complaining of being nauseous. Yeah. Give him some Zofran. Make his day a little bit better. A beta-adrenergic blocker would counteract all the following medications except which one? Okay. So we have isoproterenol, right? That's stimulates your beta. So that would not work there. Norepinephrine is or atropine, right? Usually goes through the parasympathetic pathways, not the sympathetic pathways. So, okay, maybe. Isoproterenol, right? This is breathing treatment. Norepinephrine, that's along the sympathetic, so it would damper, or beta blocker would damper its effects. Epinephrine, same thing. Okay, so your answer is atropine. I wish it would let me scroll the annotations up. Unlike an idioventricular rhythm, an agonal rhythm does not produce a palpable pulse. Okay, yeah, probably. Is associated with a faster rate. No, it's pretty much the same. These two are like the same thing. Associated with a lower mortality rate. Definitely not. Indicates a regular ventricular pacemaker. I mean, it's regular and it's ventricular, but it's not. That's not what you want in your cardiac life. Your best answer is does not produce a palpable pulse. Because again, remember, idioventricular and agonal are both coming from the ventricles. Agonal doesn't have a pulse. Idioventricular does. To increase myocardial contractility and heart rate to relax bronchial smooth muscle, to relax bronchial smooth muscle, you must give a drug that what, right? So this sounds like a beta blocker to me, right? Because we want to, or sorry, it needs to, hold on. A beta stimulator, not a beta, the opposite of this, a beta stimulator. Not enough coffee. Right? Because you want increased heart rate and you want to relax the bronchial smooth muscles. So, no, we don't need to deal with alpha receptors because these are both on the beta side. So we're not gonna deal with alpha receptors. Again, we're not gonna deal with alpha receptors here. And now we're gonna block the beta receptors or stimulate them. We want to stimulate them. Do what they're supposed to do. Ooh, okay. A loud S3 heart sound when heard in older adults often signifies, and this is a little bit of another memorization. It's heart failure, right? S3 heart sounds are associated directly with heart failure especially in older adults. Common signs of left-sided heart failure include all of the following except, excuse me, hypotension, hypertension, yeah, usually, right, because remember you have increased or decreased ability to pump. So the heart's pushing, a weakened heart is pushing against increased afterload, right? So your blood pressure will be up. And traditionally, the left-sided heart failure is brought to you by hypertension. Tachycardia, again, the heart's going to have to pump harder in order to move blood around the body. Confusion, right? Because patient might start becoming confused. Secondary to a decreased, decreased pumping action. So your best answer is hypotension. Untreated ventricular tachycardia would most likely deteriorate to asystole. I mean, yeah, eventually. It's not wrong. Pulseless electrical activity, no. Usually, if it's tachycardic, it will go right to ventricular fibrillation, right? Because we talked about that degeneration where it goes from like tachycardic to starts losing some of its form, right? It becomes fibby. Torsades de pointe or torsades de pointe, right? Is that turning on the angle when it's polymorphic? You're not going to add pacemaker sites as it starts to deteriorate. You're going to lose. Okay. You are treating a 54-year-old man in VFib arrest after delivering 2 shocks, 1 milligram of epi, and 300 milligrams of amiodarone. You restore spontaneous circulation. Good job. Patient's blood pressure is 96/60. The cardiac monitor displays a sinus rhythm at a rate of 70 beats a minute with frequent PVCs. Appropriate post-resuscitation care for this patient. An infusion of amiodarone, maybe. Crystalloid bolus, again, maybe. His blood pressure is pretty good right now. I don't know if I would flood him with water. Atropine, no. His heart rate's okay. Low dose dopamine infusion, no. Like, he's clinically presenting pretty good. Blood pressure's okay. Heart rate's okay. So the crystalloid bolus would really be intended to bolster his blood pressure, but your biggest problem right now is that he went from VFib arrest to a rhythm that has frequent PVCs. So you need to calm down those ventricles. That means that your best choice is amiodarone. Most significant risk associated with the use of fibrinolytic therapy, and this is why we don't carry it on the ambulance, right? Fibrinolytic therapy breaks down clots and improves bleeding, right? This is what we use for strokes. So it's not going to be coagulation. That means it's blood clotting. This is doing the opposite of coagulation. No. Reocclusion, again, opposite. Anaphylaxis, that's just actually a really strong possibility for anaphylaxis, but that's, the biggest issue here is hemorrhage. Fun story, patients who get fibrinolytic therapy tend to get Benadryl with it, because it does have a high, a high risk of causing allergic reactions. It's just the magic of that medication. All right, moving along. Oh, so close. All right, following 2 minutes of CPR on a pulseless unresponsive man, you check the monitor, which gives you VFib. What should you do? And this is pure BLS, this question. You've got a patient who's in VFib. What are you going to do? You're going to charge. You should defibrillate, right? Hopefully. So you're not going to establish an IO. You're not going to reassess in 2 minutes. You want to shock him. Continue CPR and intubate? No. You're going to resume CPR as the defibrillator is charging, right? Because it's good medicine now. If you're the one pushing the button, you can't shock yourself. Normally, the ST segment should be, and this one is another one of those just basic knowledge kind of ideas. Hi, Roger. It should be at the isoelectric line, right? And you don't want an elevation or depression, and you better be seeing it, right? So, cardiac-related chest pain is often palliated by, and this goes back to BLS days a little bit, right? You have provocation. Right, what makes it worse, and palliation, what makes it better. So, exertion often is a provocator, stress, provocator, nitroglycerin, makes it better. Mild exercise, provocation, right? So your answer should be nitroglycerin. All right, on a roll now. Which of the following medications is a calcium channel blocker, right? And this you should just know straight up off the bat because it's also part of your protocols, and that's Cardiology. Okay, it should also be like the only familiar medication on this list. Fibrinolytic medications are beneficial to certain patients with an acute MI because what is the action, right? So, does it convert plasminogen to plasmin to destroy a clot? No, I don't believe so. Maybe it does, yep. Decrease circulating platelets within the blood? No, it doesn't decrease platelets. Does it break down the plasmin concentration inside a blood clot? No. Destroy a clot by releasing fibrin into the bloodstream? No, because fibrin builds a blood clot, so converts plasminogen to plasmin to destroy a blood clot. Come on, mouse. Duration of a QRS complex should be how many milliseconds or less? And again, this is a pure memorization. Right, it should be 120 milliseconds or less. Firing of artificial pacemaker causes what? Okay, so a change in the shape of the preceding P wave? No. If its P wave has already happened, it's not going to change its shape. A wide QRS complex followed by a vertical spike? No, that's backwards, right? Usually you get the vertical spike and then you get your rhythm. So no. Small spike followed by a narrow QRS complex? No, your narrow QRS complex would indicate that you're going down the correct pathways. A vertical spike followed by a wide QRS complex, there's your best answer. Administration dopamine or any other vasopressor drug requires online medical control approval. See, this right here is wrong because not everywhere would you have to necessarily call for dopamine. An electromechanical infusion pump. I mean, they did just put that into our protocols if available. So it's good medicine, but not the right answer here. Careful titration of blood pressure monitoring, yes. Concomitant crystalloid fluid boluses, no. Best answer. Careful titration. Which of the following EKG abnormalities is most consistent with hyperkalemia, right? So we talked about hyperkalemia gives you tall, funky, pointy T waves. No J wave. Prolonged QT intervals usually a calcium issue. Prominent U waves is usually hypo. Oh my goodness. Cold. Having a brain fart. So tall peaked T waves. Patients with a heart rate greater than 150 beats a minute usually become unstable because increased right atrial preload. No, we don't really care about the atrias when it comes to tachycardias. We're worried about the ventricles. Reduced ventricular filling. Yeah. An increase in the atrial kick. That's going to increase your blood pressure. A significantly reduced afterload. No, because we're talking about inside the heart, not outside the heart. Afterload's outside of the heart. Reduced ventricular filling, right? Because the heart rate gets so fast that the heart doesn't have a chance to refill, so you get lower and lower blood pressures. A pure alpha agent. Okay, so what does an alpha agent often do? Right, we have your ABC. Oh, hold on, just turn the annotation back on. Right, so you have your ABCs. Alphas constrict and betas dilate. So where's constriction, right? Okay, so we have decreased blood pressure by dilation. No. Direct effect on the heart rate. No. bronchoconstriction, moderate bronchoconstriction. No, it's usually the beta, right? The lungs, because you have one heart and two lungs. So your alpha doesn't really impact the lungs directly. So marked vasoconstriction. Pericardial tamponade can be differentiated from attention pneumo by the presence of what exactly, right? So in both of these, you're going to see that, hold on. Yeah, you're going to see jugular vein distension, right? Because the pressures are building up inside the chest. It's going to push that blood back up into the JVD region. Clear and equal blood sounds, or breath sounds, maybe. Alterations in the QRS amplitude, possible. Okay, but again, you see that with both of them. A narrowing of the pulse pressure. Again, you're going to see that with both of those as the heart starts to get crushed, smooshed. You're going to have a narrowing of the pulse pressure. So clear and equal breath sounds, right? Because in attention pneumo, you're going to not hear it on one side versus the other. On the EKG strip, a third-degree AV block usually appears as. So, most of the time, right, depending on where the QRS is coming from, most of the time it's not going to be coming directly from the AV junction. So you can cross out narrow QRSs. Right, so it should be a wide QRS complex. Now, is your QRS complex going to be at a rate between 50 and 70? Again, if it's coming from the here we go, here's a picture again, SA, AV, if it's coming from below the AV junction, it's going to be 40 to 60. 50 to 70 means it's above the AV node, which means it's not third degree heart block, right? Because this is where your block is. Best answer is slow wide QRS complex with inconsistent PR intervals, right? Because again, remember, the P waves and the QRSs, that's not a QRS, are no longer married. Which of the following statements regarding sinus bradycardia is correct? Where's my pen at? Come on, pen. Symptomatic bradycardia is caused by decreased atrial rate. No, not necessarily. No. Treatment focuses on the patient's tolerance to the bradycardia. Yeah, so far. Because are you going to treat, just like go back to that gym question, are you treating that guy with a heart rate of 46 who happens to be in really good shape? Sinus bradycardia often requires multiple doses of atropine to correct it. Generally, no. Generally, we just give that one, right? Other places, or they change the protocols a little bit so you can give more, but if it doesn't work the first time, we move on to transcutaneous pacing. Sinus bradycardia is caused by decreased vagal tone in most patients. No, it's not decreased, it's increased vagal tone. So your best answer here is that treatment focuses on a patient's tolerance, right? Because if the patient tolerates a bradycardia, are you going to treat it? No. Bring them to the hospital and let them deal with it. Cardiac output, right? We talked about cardiac output. Cardiac output is one of those things that you need to know, right? Cardiac output is your stroke volume, your heart rate, and your stroke volume, right? Oh, looky here. Do we measure ejection fraction? Hi, Roger. Ow. Oh, it's got attacked. Happy morning, dog. Epinephrine is used to treat patients in anaphylactic shock because of its effects of increased heart rate and automaticity. I mean, yeah, it does that, but that's not helping us in anaphylaxis. Bronchodilation and vasoconstriction, right? Yeah, because in anaphylaxis you have bronchoconstriction and vasodilation. Vasodilation and bronchoconstriction, no, because this is actually right here is the definition of anaphylaxis of no. Parasympathetic nervous system blockade. No, just no. Bronchodilation, vasoconstriction. All right. Ischemia to the anterior wall of the myocardium. So we're going to bring up our example 12 lead again, right? V1, V2, V3, V4, V5, and V6. We have septum, anterior, lateral, and in your inferiors 2, 3, and AVF, right? 1 in AVL hangs out over here at V5 and V6 in the lateral. So we're looking for the anterior wall. So this is a lateral wall. V3 and V4 is anterior, so we'll hang on to that for now. V3 and V4 is anterior. 2, 3, and EVF is inferior, so we'll get rid of that one. So ischemia, right? We talk about ischemia. We are expecting T wave to be inverted, right? Because we don't get to segment elevation until injury. So here's your best answer. Vasoconstriction occurs following stimulation of, right? Oh, we're back to here. A, B, C, D, right? Alpha constricts, beta dilates. So we're looking for further vasoconstriction. So anything that's got a beta in it is wrong. Alpha. Which of the following electrolytes maintains the depolarization phase? Again, this is a little bit of memorization. It's also a little bit of what we talked about, that prolonged QT, right? We talked about this is caused by calcium, right? So if it's our depolarization is prolonged, or that repolarization is extended. That means that the depolarization is extended. Calcium. Changes in cardiac contractility may be induced by medications that have a positive or a negative blank effect, right? So we're talking about cardiac contractility. So, vasoactive, that's a throwaway, right? Chronotropic, dromotropic, right? Remember I said remember these, your inotropy, chronotropy, and dromotropy. Contractility is your inotropic effect. Okay. Oh, I gotta move it down a little bit. Which of the following statements regarding a second-degree heart block is correct? 10. Second-degree heart block characterized by inconsistent PR intervals. QRS complex greater than 0.12. And a ventricular rate of less than 40. I mean, you could have a heart rate more than 40, right? I would say that's a no. More than half of all second-degree heart blocks cause hemodynamic compromise, require transcutaneous pacing. Who's calculating this? This more than half, right? This right here, more than half of all. That's just one of those like, no. Most second-degree heart blocks are transient in nature and resolve in a pre-hospital setting without need. No. I mean, transient nature, that means it comes and goes, right? You get there, the patient's like, I don't feel good. And then you get to do stuff. Second-degree heart block occurs when an impulse reaching the AV node is occasionally prevented from proceeding to the ventricles and causing a QRS complex, right? That winky back, or even this second-degree type 1, type 2, right? You have that dropped beat. There's your answer. S1 heart sounds. What does it represent? Right, so the heart sounds are due to the closure of heart valves. Closure of heart valves. So that means it's not the end or the beginning of atrial contraction or ventricular contraction. But is it the mitral or and tricuspid, or the aortic and pulmonic? The answer to that is A, mitral and tricuspid. That's just a knowing that knowledge there. All right. Electrical capture during transcutaneous pacing. Come on, where's my pen? Thank you. Is characterized by presence of a strong pulse despite a slow rate. Maybe. We'll hang on to that for now. Low amplitude QRS complex is preceded by... Oh, but wait. Electrical capture, right? Strong pulse is mechanical capture. So that's incorrect. Low amplitude QRS complex is preceded by a pacemaker spike. No. Narrow QRS complex is preceded by a pacemaker spike. No, because it's not going to be narrow, right? And it also shouldn't be low amplitude, right? Your QRS complex is if you're like electrocuting them, right? You're sending a little bit of electrical wave into their heart. It's going to be a pretty decent sized QRS. Pacemaker spike followed by a wide QRS complex because it's not following the traditional pathways. That's your answer. A run of VTAC occurs if at least blank PVCs occur in a row. Again, it's just a simple memorization. It's 3. 2 is just like couplets. 3, bad day. You are assessing the 12 lead of a 40-year-old man with chest pain and note ST segment elevation in leads 2, 3, and AVF. So that should give you the idea that it's inferior. Okay. Lead V4R shows a 2 millimeter ST segment elevation. Okay, so that to me means that the right ventricle is involved. Bad day. Patient's blood pressure is 88/58, as indicated by the fact that his right ventricle is involved, and his heart rate is 72 beats a minute regular. Okay, good. Denies any significant past medical history, is allergic to salicylates. After placing a patient on oxygen and starting IV, what should you do? Okay. Start a dopamine infusion. Maybe. His blood pressure is a little crap. We might want to do a dopamine infusion. Do we want to put that much stress on the heart? Probably not. Administer up to 325 milligrams of baby aspirin. No, he's allergic to salicylates. This is the trick question here for this one. Baby aspirin has a salicylic acid. Give crystalloid boluses to increase preload. Yeah, 2 milligram increments of morphine. I mean, that's nice, but you're gonna continue to tank his blood pressure if you give him morphine. So your best answer is your crystalloid boluses. All right, moving on. I'll get excited for a blank page for a second. All right, QT interval most likely be prolonged in a patient who. Remember we talked about this a number of times. Question problem. It says hypercalcemic. It's hypocalcemic. Is the answer. It's a typo. So this is the correct answer, but there was a typo in the question. So we talked about this before, right? QT interval is directly related to calcium in the blood. Low calcium, prolonged QT interval. This was a boo. All right. That would have been a throwaway, yeah. You're welcome. Which tachycardia, hold on, that's in English. Which of the following factors would present the greatest difficulty when distinguishing supraventricular tachycardia with ventricular tachycardia? Sorry, I missed this weird little blurb there. Right, so SVT goes down the normal electrical pathways, while VTAC does not, right? Goes up the other way. Goes from cell to cell to cell, which is aberrant conduction. Okay. Sometimes you can't see the P waves. Sometimes the rate of an SVT and VTAC are about the same. And sometimes you can't even tell if there's quote unquote retrograde conduction or not. All right, this is also. You were called to the scene of a 4-year-old male struck by a van. You attempt peripheral IV 3 times without success. You are mean. Kid got hit by a van already. Why are you going to hit him with an IV 3 times? Best course of action for administration of fluids and medications in this situation if the child is in cardiopulmonary arrest is what? Without it should, for a child, it's always an IO. Okay, you're not going to futz around trying to get an IV in these little teeny tiny veins. It's just wasting time. According to Einthoven triangle, lead 2 is assessed by, right? So, the leg, what is going on? The leg is always positive, right? Legs are always positive in Einthoven's. And then you have a positive on the right and a negative on the left. Okay, so this is, again, just remembering what your what Einthoven triangle looks like. So your answer is going to be, oh, sorry, I had this backwards. Negative, positive. I got my, this is the right arm, left arm, legs. A little dyslexic there. So it's going to be a negative lead on the right arm and a positive lead on the left leg, right? Hypertension is present when blood pressure is above 160 systolic during strenuous exertion. No, your blood pressure should be there. That's a good thing. That's means your body's working. It's consistently greater than 140/90 while at rest. Yeah. Rises acutely during an emotionally stressful situation. Again, that's a normal compensatory mechanism. Increases by 20 millimeters of mercury above the person's normal blood pressure. That doesn't impress me. Is consistently greater than 140/90 while at rest. All right. If an increased amount of blood is returned to the heart, cardiac workload is decreased, resulting in decreased cardiac output. No, because if you increase blood, you're increasing preload, which means Starling's principle of the heart. That's ridiculous. Starling's principle of the heart rate, you're stretching that muscle more, so you're going to have an increased cardiac output. Stroke volume decreases accordingly because of larger volume. No. Increase of stroke volume occurs because the heart rate increases. This is not talking about increasing in the heart rate. A cardiac muscle must stretch to accommodate larger volume. Yes, this is Starling's principle. A 17-year-old man complains of palpitations and lightheadedness that began suddenly about 20 minutes ago. Blood pressure is 118/74, pulse is rapid, respirations 18 breaths a minute. Cardiac monitor reveals narrow QRS complex tachycardia at 180 beats a minute. You're applying supplemental oxygen, cardiac rhythm spontaneously converts to a sinus rhythm. Closer evaluation reveals a rapid upslope in the R wave immediately after the end of the P wave, which is correct. That Osborne wave here is usually hypothermia. That's the word I couldn't remember before coffee finally kicked in. There's a delay in ventricular depolarization. No, his ventricles are depolarizing just wonderfully if it's maintaining a rate of 180. EKG abnormality is caused by a failure of the AV node. I mean, you would have him in AFib, but yeah, it's a failure of the AV node to block multiple conductions into the ventricles, but he's not. He's in sinus. That rapid upslope of the R wave is indicative of Wolff-Parkinson-White. In contrast to the pain associated with acute MI, pain from a dissecting aortic aneurysm is not often preceded by other symptoms. It doesn't wax and wane. It doesn't become gradually severe. It is maximal from the onset. All right. Injury to the inferior wall of the myocardium would present with, right? So we talked about this before. 2, 3, an AVF or your inferior wall. So you won't have T wave inversion in leads 1 through V4. No. You're gonna have ST elevation in the leads here, right? And pathologic Q waves mean that there was injury in that direct area. ST depression, V for an AVL, that's not what you're looking for. T wave inversion, no, it says you're going to have ST elevation. Which of the following statements regarding the SA node is correct? Dominant cardiac pacemaker in healthy patients. Good, yeah. No, located superior aspect of the right ventricle. No, it's in the atrium. Impulses generated by the SA node travel through the right atrium only. No, it goes through the whole heart. SA nodal ischemia occurs in the left coronary artery, is occluded. No, it's the right coronary artery that gives the SA node its blood. Main pacemaker in the heart of a healthy patient. When performing CPR on an adult patient in cardiac arrest, it is important to, this is back to BLS, right? 80 to 90 compressions a minute is not enough. Allow the chest to fully recoil between compressions. Yes. Deliver forceful ventilations. Not if you don't want to be covered in vomit. Limit interruptions in chest compressions to 20 seconds. That's a really long time. Allow chest to fully recoil. 56-year-old man complains of chest tightness and nausea. During your assessment, you note that he appears confused, diaphoretic, and short of breath. Blood pressure is 98/68. And you feel a rapid radial pulse. Cardiac monitor reveals a wide QRS complex at a rate of 200 beats a minute. After administering oxygen, what should you do? Attempt to slow his heart rate, vagal maneuvers to start an IV. I'm going to go with no, because he's confused. Good luck getting him to try to bear down. Establish IV access, consider sedation, perform synchronized cardioversion. I like that one so far. Establish vascular access and administer 150 milligrams of amiodarone over 10 minutes. This right here, right? This is your medicine or Edison decision. Obtain a 12-lead tracing, determine origin. He's 200 beats a minute and he's confused and hypotensive. You're not going to necessarily do that EKG right now. Your best option is synchronized cardioversion. Your paramedic unit responds to a cardiac arrest call. Patient is intubated successfully. You are ordered to administer 1 to 10,000 epinephrine solution via the endotracheal tube. Why is this acceptable? It is not more reliable than IO. Acceptable because the large surface area available for the absorption of medication in the respiratory tract. Yeah. It is not more reliable than IV, because remember, IV and IO are the same reliability. This is not an acceptable method of drug administration to cardiac arrest patient. Unfortunately, it is. It's just not used much anymore because it's just kind of unreliable at best. Yeah. Come on. Get back to me, pen. Process of an aortic dissection begins when blood accumulates between the layers. Well, it's got to get in there first. Intimal layer of the aortic wall is torn. Yeah. Hypertension causes an acute rupture. It's no, because most of the time aortic dissection is a slower process. The aorta is weakened due to excessive pressure. Intimal layer is torn. Aberrant conduction is blank conduction. Very slow, abnormal, rapid, or irregular. Abnormal, right? Because it's not, you're not following that SA, internodals, AV. It's going from cell to cell to cell, very slowly. So it's going to be wide, but it's not necessarily going to be very slow. It's just going to be slower. All right, patients who are experiencing an infarction of the right ventricle may present with significant hypotension. Yeah. Often require high doses of nitro. No. Don't do that one. No. Usually hypertensive and tachycardic. No, because remember we talked about inferior wall and 2-3 in AVF. How you do that V4R to see if there's right ventricular involvement, and if it is, that's when you don't give nitro because they're going to be hypotensive. Should not be given IV fluid boluses. They should. They should. We just saw that a couple questions before, right? They have a patient with a V4R elevation. This is what you're going to do for them. You're going to give them this IV fluid bolus. So your best answer is significant hypotension. Which of the following drugs possesses beta 2 specific properties, right? Okay, so we've got Proventil, right? So this is your albuterol, because you have beta 1, heart, beta 2, lungs. That's a terrible picture. Dopamine, no, that's beta 1. Levophed, it's beta 1. Epinephrine is both, or actually Levophed is alpha. This is beta 1 and 2. We want beta 2 specific. Proventil. Leads V1 through V3, right? So let's go back to our handy dandy V1 through V3 is interoceptal. Depolarization, the process by which muscle fibers are stimulated to contract, occurs when? All right. Potassium ions escape. No, that's later on. It's not during depolarization. Cardiac muscles relax in response to a cellular influx of calcium. No, a cellular influx of calcium causes contraction. Cell wall permeability changes and sodium rushes into the cell. Yeah, because that's what increases the positive ions in the cell. Calcium ions rapidly enter the cell, facilitating contraction. Calcium ions aren't rapid, they're kind of slow. Okay. It's also, this is not part of depolarization. This is part of the contraction side again. This is the mechanical, not the electrical. In contrast to coarse ventricular fibrillation, fine ventricular fibrillation indicates that arrhythmia is more likely to respond to defibrillation. Unfortunately, no. Cardiac cells temporarily have adequate energy stores. Quite the opposite, actually. Energy reserves of the cardiac cells have been expended. Yes. Perfusing rhythm is not possible. I mean, it is. It's still kind of possible, but this is right here. That's your clue. Not possible. That's like your multiple choice clues. It's never an impossibility for the most part. The circumflex branch of the left coronary artery supplies which wall of the left ventricle? And remember, we had that nice little, whatchamacallit, that nice 12 lead picture that we came up with. That was in the lecture. All right, here's your V1, V6, 1, AVF, right? So you had your left anterior descending. So these over there. And then you had your left circumflex, which came down here. And then you had your right coronary artery. So the right answer is your lateral wall. In the context of cardiac compromise, syncope occurs due to increase in vagal tone. I mean, yes, but that's not a cardiac compromise issue. Sudden cardiac dysrhythmia. No, not necessarily, because you can have a sudden cardiac dysrhythmia that doesn't affect the blood pressure, right? A drop in cerebral perfusion. I like that one so far. An increase in heart rate. Yeah. Drop in cerebral perfusion, right? That means that either it's a fast rhythm or a slow rhythm that's causing the brain to not get enough oxygen. The most effective drug for the treatment of non-vago-induced bradycardia. Okay. Metoprolol, that's just going to make it slower. Dopamine, I mean, perhaps. Atropine, I mean, again, perhaps. Epinephrine, again, possibility. So, which is going to be the best answer here? And again, this is maybe one that I would probably have changed this from most to least, because all of these can and will have a impact on bradycardias. The answer is epinephrine, but this is another one I don't like now. You were dispatched to residence for an elderly man who states he was awakened suddenly at 2 a.m. feeling like he was being smothered. You note the patient is short of breath and has dry blood on his lips. The patient tells you he has some type of breathing problem, for which he uses a prescribed inhaler and takes a heart pill. What should you suspect? All right, so if you have right ventricular failure, right, if the fluid goes back from whence it came, it's going to be in the legs. Reactive airway disease and COPD, right, they kind of hang out together. But do they make you feel like you're being smothered? No, probably not. And they also aren't things that wake you up suddenly, right? Left-sided heart failure. This is your answer. Right. Also, that clue is the dry blood on his lips, right? That's usually a good significant finding for APE, which is associated with left-sided heart failure. Whoop, too far. Anatomically contiguous leads. What do they view? Come on, Ben. Only the anterior wall of the heart? No. Opposite walls of the heart? No. Only the lateral wall? No. The same general area. Once an advanced airway device has been inserted into a cardiac arrest patient, ventilation is delivered at a rate to 8 to 10 breaths a minute. Yeah. Compressor should pause so ventilations can be given. No, we don't pause. We have an advanced airway now. We don't need to pause anymore. You should deliver 1 breath every 5 to 6 seconds. No, that's rescue breathing. Chest compression should be increased to 120 a minute. They should have been there already. Ventilations are delivered at a rate to 8 to 10 breaths a minute. A somewhat anxious 33-year-old woman states that she is experiencing an acute onset of fluttering in her chest. She's conscious and alert, denies medical problems, states she's under a lot of stress at work. You apply the monitor, which reveals a narrow QRS complex, tachycardia, at a rate of 170 beats a minute. The patient's blood pressure is 140/90. She's breathing without difficulty. Most appropriate treatment for this patient. So, we have vagal maneuvers, IV access, and cardism. Diltiazem is usually kind of reserved for your AFib. Also, this option has no oxygen. Not the answer. Oxygen, IV access, vagal maneuvers, and 6 milligrams of adenosine. I like that one so far. Oxygen, emotional support, and 2.5 milligrams of midazolam. I mean, no, because executed as it is that we're trying to calm her down from her quote-unquote anxiety attack, she's having a cardiac issue. Oxygen, vagal maneuvers, and emotional support. Again, she's having a cardiac issue. I don't know what emotional support is going to do. 6 milligrams of adenosine, right? This is your primary treatment for SVT. Which of the following patients would most likely present with atypical signs and symptoms of an acute MI? 71-year-old woman with hypertension. I mean, she's a woman, so quite possibly. 49-year-old obese man. No. 58-year-old diabetic woman. Or 60-year-old man with anxiety. Most likely, it's going to be your female diabetic. Which of the following statements regarding an idioventricular rhythm is correct? The common cause of idioventricular rhythm is a failure of the SA node. I mean, if this said AV node, perhaps. But no, there's a lot of other stuff standing between the SA node and the idioventricular pacing. Treatment for idioventricular rhythm focuses on increasing the blood pressure, possibly. Most patients with an idioventricular rhythm are hemodynamically unstable. Yeah. Idioventricular rhythms are typically accompanied by non-conducted P waves. No. Well, idioventricular are hemodynamically unstable. All right, you are assessing a conscious middle-aged man who complains of chest discomfort and nausea. Blood pressure is 112/70. Pulse is 90 beats in regular. Respirations 20 breaths a minute regular. Patient's past medical history is significant for hypothyroidism and hyperlipidemia. Medications include Synthroid, Lipitor, Cialis, and 1 baby aspirin a day. Which of the following medications would you least likely administer? And this is one of those knowing what your medications are, because Cialis is an ED med, which means that nitroglycerin is your answer. Especially when you have a blood pressure like 112/70, like that plus Cialis is going to be a bad day. All right, so lead 1 views the blank wall of the heart, while lead AVF views the other wall of the heart. So let's go back to our handy dandy drawing, right? So you have 1, 2, 3, AVR, AVL, AVF. So these are your lateral, and these are your inferior. So lead 1 is the lateral, is in the AVF is the inferior A. A diagnosis of an acute myocardial infarction is made if ST segment elevation, right? I just fill that in right there. Elevation of 1 millimeter is seen in 2 or more contiguous leads. For an antiarrhythmic medication, an initial dose for refractory pulseless ventricular tachycardia. I mean, this one should be pretty. This is like, you know, your protocols, and you know your cardiac arrest protocols, which are going to be probably some of the most commonly used ones. Amiodarone. We don't carry procainamide. Lidocaine is only used currently in protocols for conscious IOs. When reviewing a patient's medication list, you notice that she's taking bisoprolol. You recognize that this is blank and it's classified as a blank. So, even if you don't know what bisoprolol is, you should know the LOL ending and look for beta blocker. There's your answer. Which of the following conditions would most likely cause the blood pressure to vary between the left arm and the right arm? I don't know how right got over there. It's over there. Right arm, left arm, and the right arm. And we talked about this already, right? Aortic aneurysm. In sinus bradycardia, QRS complexes are often wide. No, I mean it's coming from the SA node. It's going down to the AV node. And it just happens to be a little slower than usual. P waves are consistently upright, maybe. Heart rate is less than 70 beats a minute. I mean, yes, but it should be less than 60 beats a minute. The pacemaker site is at the SA node. Right? If it was not sinus bradycardia, if it was just in a bradycardia, okay, it would be different. A major complication associated with AFib is, right, we talked about this, as those atrias are just kind of shaking, they're not, you lose that atrial kick and that blood kind of stagnates inside the atrias, which increases the likelihood of a clot. So, here's your answer. Clot formation in the fibrillating atrias. Which of the following statements regarding asystole is correct? P waves only? No, asystole is a flat line. Asystole results of prolonged myocardial hypoxia. Yeah. Disconnected EKG often mimics asystole. No, because this is the difference between, ready, asystole and a disconnected EKG lead. Defibrillation is indicated in some cases of asystole. Only if you bring your own doctor. And he says, I think that looks like very fine VFib. Asystole results of prolonged myocardial hypoxia. All right. PR intervals that vary from complex to... Oh, wait, hold on. I should get the answer question, huh? AFib can be interpreted by noting. P intervals that vary from complex to complex? No, because you don't even have PR intervals in AFib. Irregular rhythm with absent P waves? So far, yes. This is my answer. Presence of wide QRS complexes in a rapid rate? Not necessarily. Irregular rhythm with abnormal P waves? No, that's more describing a second degree heart block, right? Irregular AFib is your irregularly irregular rhythm. The mitral valve is, all right, so this goes back to kind of remembering your whatchamacallit, your heart anatomy. What side of the heart is the mitral valve on, right? So the mitral valve and the tricuspid are the two that are paired. The tricuspid's on the right side, the mitral's on the left side. So, no, it's not on the right side of the heart. Separates the right atrium from the right ventricle? No, because again, it's still on the left side of the heart. Prevents blood regurgitation to the right ventricle? No. Your obsession with the right side of the heart is cute, but no. It's on the higher pressure side of the heart, which is the left. Wandering atrial pacemaker is generally faster than 100 beats a minute. No, not necessarily. Consistent P wave shapes. No, because, right, remember the definition for a wandering atrial pacemaker is 3 or more P wave shapes. Has a very variable PR intervals. Yeah, generally treated with atropine. No, because if it's a good heart rate and your patient's, hemodynamically stable, you're not going to treat it at all. Working on a patient who's in cardiac arrest. You've attempted an IV in the right antecubital fossa. Let's draw. Too many fingers. Okay. Right. So you've tried an IV in the right antecubital fossa, right there. Multiple attempts has resulted in the vein blowing. Oh dear. What is the next appropriate site for the text attempt? So you're not going to be touching the femoral artery. That's above your pay grade. The right forearm and the right hand are below the sites of the blown vein here, so you're just going to increase the mess that you've made in this arm. Left AC. A patient with a medical condition that requires antiplatelet therapy would most likely be taking. Again, if this is one of those things where you're like, I don't really know all of these medications, right? So Coreg is traditionally a high blood pressure medication. Zocor is used for high cholesterol. Altase, I don't remember Altase. But Plavix, I know that we have patients who have like AFib, etc., who take Plavix. You can almost always narrow it down to at least 2 options. It is most important to evaluate a cardiac arrhythmia in the context of, okay, and this goes back to that guy at the gym question, right? What's going to prompt you to treat a cardiac rhythm or cardiac arrhythmia? It's going to be the patient's overall condition, right? They might have a heart rate of 38, but they're doing A-okay and their blood pressure is good, right? And none of these other things are going to matter. When viewing leads V3 and V4, what wall of the heart are you looking at? Back to the drawing board. Septal, anterior, lateral. Oh, there we are. Anterior wall and the left ventricle. There's your answer. Which of the following pulseless rhythms is not treated as a PEA? We talked about this, right? Idioventricular is PEA. Junctional escape rhythm is treated as a PEA. Sinus bradycardia is treated as a PEA. Ventricle tachycardia is the only one that has its own, right? VFib and VTAC have their own protocol. They're treated differently. Which of the following situations would contraindicate the administration of nitroglycerin? Tadalafil use within the last 24 hours. Maybe. I don't remember what tadalafil is, right? Maybe that's what... I'm not sure what this is. Systolic BP less than 110. Now we get to do nitro up to 100. Systolic BP of 100. Hypersensitivity to salicylates. No, that's aspirin. Doesn't have anything to do with nitroglycerin. Use of Plavix within the last 12 hours. No, that's fantastic. You should be having less of a heart attack. Tadalafil is one of your ED medications. During the refractory period, what is going on? Right, so the heart is partially charged but cannot contract. No, the heart has been discharged, really. It's been depolarized, right? So heart is at a state of partial repolarization. Yeah, sort of, but not quite. We'll hang on to that one for now. Heart muscle is depleted of energy and needs to recharge. No, it's not an ion battery. The cell is depolarized or in the process of repolarizing. Yes. The refractory period is that transitionary phase. What is the R on T phenomenon? Be my pen back. All right, when the R wave occurs at the J point of the next cardiac cycle, no, that's not quite it. A premature ventricular complex that occurs when the ventricles are not fully repolarized. Yeah, I like that one so far. A PVC that occurs during a time when the ventricles are depolarizing. No, because that won't make a difference, right? That's not going to cause a dysrhythmia. They're already depolarizing. It's going to continue depolarizing. A unifocal PVC that occurs during the upslope of any given T wave, right? We talked about the absolute and the relative refractory period. Right? So the absolute doesn't matter. You can poke this as much as you want. It's not going to cause another impulse, but if you hit enough energy here in the relative refractory period, it will be an issue. So your answer is B. Most common cause of cardiac arrest in adult patients is acute MI, maybe. Respiratory failure, no, that's kiddos. It's hypoxia. Electrocution, no. Dysrhythmia. Right? Oh my. Okay. A pulse that alternates in strength from one beat to the next is called, and I know this is Danny Wan's favorite, one of his favorites. It is the pulses alternans, right? Alternates, alternans. If it's a QRS complex that is different in size from one to the next, that is electrical alternans. Response to residence for a 44-year-old man feeling ill. Patient missed his last 2 dialysis treatments because he was not feeling well. Partner takes the patient's vital signs to apply the EKG, which reveals a sinus rhythm with tall T waves. 12 lead is a sinus rhythm with inverted complexes and lead AVR. Inverted complexes in AVR, that is normal. That is, right there is a distractor, but you want inverted complexes in AVR. On the basis of your clinical findings, which you should be most suspicious that the patient is a dialysis patient with tall T waves, hyperkalemic. Acute coronary syndrome is used to describe any group of clinical symptoms consistent with an acute myocardial ischemia. Maybe, I'll hang on to that. Clinical condition in which patients experience chest pain during exertion. No, that's pretty specific. A sudden cardiac rhythm disturbance that causes a decrease in cardiac output. No. Acute chest pressure or discomfort that subsides with rest or nitroglycerin. Now that's stable angina. Sorry, the dog just ran to the room looking like a goofball. All right. We're gonna do like one more page, and I will record the rest of these later because it's a little. We're running out of a little bit of time. I have things. I have a meeting a little later I have to go to. Stimulation of the parasympathetic nervous system causes all of the following effects except. Okay. So, right, so the parasympathetic nervous system is going to decrease your heart rate, decrease your blood pressure. So that would mean that the force of your heart is going to be decreased, right? Your heart rate is going to be decreased. That works. Those two work. You are going to have a dilation of the pupils, right? Because it's feed and breed, which has a dilation effect, dilatory effect. Increased salivation, right? And if you kind of remember that the increased salivation is associated with organophosphate, which blocks the parasympathetic. Patient with cardiogenic shock and pulmonary edema should be positioned. How would one position this patient, right? So would you be supine with the legs elevated? If you put your pulmonary edema patient supine, I fire you. In the Trendelenburg position, again, no. Lateral recumbent, again, no. Semi-Fowler's, right? The patient should be sitting up. Which of the following clinical findings is least suggestive of left-sided heart failure? Okay, so let's see. Crackles in the lungs, yeah, that's usually a good sign. Shortness of breath, also a good sign. Sacral edema, S3 gallop, what do we talk about S3 before? S3 is heart failure, right? Sacral edema, this is associated with right-sided, right? Remember, it comes back from whence it came. Precordial leads do not view which wall of the heart, okay? If you go back to our handy-dandy little chart, right? You've got your precordial leads are these guys over here, V1, UV6, so you have septal, anterior, lateral. That covers this one, and this one, inferior wall. Thousands of fibrils are distributed throughout the ventricles, which represent the end of the cardiac system, right? So you have your beginning of your cardiac system, which is your SA node, or your cardiac electrical system, your AV node, your Purkinje fibers are at the end of the electrical system. All right. A regular rhythm with inverted P waves before each QRS, a regular PR interval, a rate of 70 beats a minute, narrow QRS complexes, and a ventricular interval of 0.16 seconds should be interpreted as. All right, so if we had to draw this, it would be something to that effect, right? So it is not an ectopic atrial rhythm because those would be upright Ps. It is not a supraventricular tachycardia again. Upright Ps would be greater than 150 beats a minute. This is at 70. Junctional escape rhythm would be originating from the AV junction, which is a rate of 40 to 60, which means that's an accelerated junctional rhythm. Automaticity, defined as the ability of the heart to, again, this is just a simple memorization, right? It is going to be able to generate its own electrical impulses without stimulation from nerves. Systemic complications of IV therapy might include, if you give someone a pneumothorax with an IV, I'm impressed. as I'm also impressed if you give someone a diverticulitis or a hemo air embolus. JVD in a patient sitting at a 45-degree angle is a sign of reduced preload. No, it's a sign of increased preload. Is not clinically significant, but just no. It is in fact clinically significant. Suggests left-sided heart failure. It's more on the right side, right? Indicates right-sided heart failure, heart compromise. All right, where are we right now? We are about halfway through, a little bit more. Yes. It's okay. I know people have to work too. It's not necessarily. I'll give it the benefit of the doubt that people are working. We'll use that excuse. It's a good one. All right. So we finished. We finished here. I'm gonna mark the spot where we finished. I will pick up and do a recording of this a little bit later. Maybe. Yeah. Yep.